Welcome to This Ability Clinic. I'm Dr. Stephanie, board certified in rehabilitation medicine and pain management. Today we'll be talking about severe back pain. Pain is our body's naturally programmed response to injury or disease. But sometimes even after an injury is healed, the body and mind's perception of the pain of that injury can persist. Sometimes no matter what you do, severe back pain just won't ease up or go away. By the end of this video, you'll understand why this can happen. Why is pain severity important? If you've ever sought out healthcare, you've probably been asked to rank your pain on a scale from 0 to 10. For a while, pain severity was thought of the sixth vital sign after heart rate, blood pressure, temperature, respiratory rate, and oxygen saturation. While pain management is vital to patient care, making it a vital sign was the wrong approach, and a lot of people are still getting too many opioids because of this mistake. Of course, opioids like oxycodone and fentanyl help with most types of pain, but they're as dangerous as heroin, and they've ruined a lot of lives. Now, don't get me wrong, opioids are absolutely appropriate in the right situation, like after a major trauma or surgery. But opioids are definitely not the answer when it comes to long-standing low back pain. Opioids are a quick fix, an emergency pain reliever that shuts down a major pain pathway. But when opioids wear off, if the source of the pain hasn't been addressed, the pain returns in full force, and with long-term use, higher and higher doses of opioids are required to suppress pain signals. This is why opioids are notorious for being habit-forming and a gateway to addiction and substance abuse. Long-term opioid use also constipates the bowels, decreases sex drive, and hypersensitizes the nervous system so that even benign activities like walking can trigger pain signals. This is called opioid-induced hyperalgesia, meaning opioids can cause extra pain. To lower pain severity, it's unfortunately much easier for healthcare providers to keep prescribing a medication that's the only one that works than to do the harder things, set boundaries, educate, and figure out a personalized plan using multiple strategies that are helpful and safe long-term. Opioids deserve their own video series, but for now, be reassured that despite a surging pandemic on top of a full-blown opioid crisis, there are doctors and nurses and therapists and psychologists and counselors and a ton of healthcare providers out there who are taking responsibility for changing our healthcare system for the better. The only way to achieve this is to work together to implement policies and practices that reduce inappropriate opioid prescribing and track more practical outcomes like function and quality of life, in addition to pain score. How is pain severity evaluated and interpreted? I always assess pain severity by asking my patients, how bad is the pain? This can be as simple as asking for a severity score from 0 meaning nothing hurts to 10 being the worst pain ever, like giving birth or passing a kidney stone. I ask for their average pain score, their highest pain score, and their lowest pain score. And this ties nicely into the conversation about aggravating and alleviating factors, since these are what cause someone's score to go up and down. I also ask about how pain limits daily activities. If it prevents someone from doing basic tasks like taking a shower, getting dressed, leaving the house, or sleeping through the night, then clearly the pain is severe enough to impact a person's function, even if they're reporting a low severity score, or even if their workup doesn't reveal a definitive cause for their pain. A pain score usually correlates with how much someone is suffering, and it gives me a starting point for how much relief they might get with treatment. A more graphic version of the 0 to 10 numeric rating scale is the visual analog scale, which you probably saw when you were a kid. But this is just the tip of the iceberg, and honestly, I think there's too many questionnaires and measures and scales for evaluating pain. It's easy for clinicians to lose sight of the big picture. I think the best approach is to concisely evaluate how much pain interferes with the important stuff: sleep, function, and quality of life. That's why my go-to questionnaire is something called the Brief Pain Inventory. The BPI,
getting all the way to the end, the BPI,
is a short questionnaire that takes 5 to 10 minutes to fill out, and it gives me all the information I need to know about where someone's pain is, their worst, best, and average pain scores, and their pain's impact on sleep, activities of daily living, relationships with others, and enjoyment of life. Check the description to see a copy of the BPI online. Pain is never just in your head. Usually we think of pain as being caused by physical injuries, but injuries also have a psychological effect, and together these influence pain severity. Pain is one of the most subjective, complicated things we treat in medicine. Two different people can sustain the same injury and have the same imaging findings, but they can each have very different experiences of pain severity, suffering, and physical limitation. I hate the phrase, the pain is just in your head, as if the person hurting is weak-minded or lacks resilience. The notion that someone who is in severe pain should just toughen up and thicken their skin is ignorant, dismissive, and frankly disrespectful. Unfortunately, this happens to a lot of people with disabling pain in the absence of physical disability. Let's get rid of that kind of thinking. The truth is, pain that doesn't have a clear physical cause is still real. It's just in your nervous system. For example, if someone comes to me for severe, debilitating back pain, but I can't discern any recent traumatic inciting event, there are no abnormalities on physical exam, or their imaging looks clean, I would describe their pain as being out of proportion to history and physical findings. This hints at a diagnosis of centralized pain, since the central nervous system, the brain and spinal cord, is inappropriately sending severe pain signals without an apparent trigger, or in the absence of noxious stimuli. Centralized pain by itself is mostly a clinical diagnosis, meaning it's invisible on routine imaging, but it's still a real cause of pain that can be detected during a clinic visit, if your doctor knows what to look for. Clues that point to a diagnosis of centralized pain include widespread non-dermatomal distribution of pain, diffuse hypersensitivity to benign stimuli like walking, light touch, or rough fabric, and coexisting psychological conditions like depression and anxiety. Check the description for more resources on pain signaling and difficult-to-treat centralized pain syndromes like fibromyalgia. Everybody experiences real pain in their own way, even when an injury isn't obvious or is already healed. The experience of pain is mostly out of our conscious control, similar to the grief of losing a loved one or the stress of living through a pandemic. Injuries can scar our bodies and traumatize our minds, and no one can consciously numb themselves to this with mind power alone. Unless you're a robot. Doctors can sometimes be too focused on lowering a pain score that they miss opportunities to help improve function, quality of life, and something very important called self-efficacy. Self-efficacy is how much you believe in yourself and your ability to do things. I know it sounds cheesy, but self-efficacy affects your motivation to cope with pain and work on things you can control, like meditating and going to physical therapy. The success of any treatment strategy depends on your belief that you can impact your pain and improve your quality of life. Doctors can help improve self-efficacy by helping patients understand the risks and benefits of their options for pain management. How can pain severity be reduced? Of course, with any pain symptom, it's important to evaluate for any pathology that could be responsible. If an offending disease can be treated, pain can usually be reduced or even resolved completely. But what about when someone's body has recovered from their initial injury and their workup is negative, but still they're experiencing persistent pain? In these cases, I make a point to reassure my patient it's a good thing that their workup didn't show anything scary. Instead of trying to eliminate pain, which is not realistic, one of my treatment goals is to decrease severity by 50% or more. Reducing a pain score, even by just 1 or 2 points, can be a clinically meaningful improvement for someone with severe back pain. Ultimately, my priorities are functional improvement and quality of life. I try to offer as many personalized options for managing someone's pain as I can think of. This is what we call using all the tools in the toolbox, and it helps build a relationship that's both therapeutic and productive. Here's an example of what I would consider a successful milestone. Say someone comes to me for severe low back pain. It's constantly at an 8 out of 10 on the severity scale, and they're not sleeping through the night or able to enjoy spending time with their family. After a few months of treatment, physical therapy, medication changes, possibly a procedure, say this patient is still reporting an average pain score of 8 out of 10, but they are able to sleep through the night, and they take walks with their family. This is amazing progress and an achievement patients and providers can be proud of. This is my goal for every single person who comes to see me. I hope you've enjoyed this overview of the most stubborn and severe types of pain. Consider joining me in changing the culture of opioid overprescribing by ranking your experience from like to subscribe. Tune in next time for a breakdown of all the different treatment strategies for back pain. We'll be rummaging through that toolbox. Thanks for watching.